Good afternoon, everyone, again. If people can take their places, you can bring your food to the table. It's okay. We allow eating. And we will shortly start the seminar. As you know, the seminar is also being broadcast on the internet as a webinar, so we will have an audience outside of WHO. So I'd ask at question time people to give their names so that people can also follow the discussion as well from who's not here present. My name is Human Momen. I'm coordinator of WHO Press, and I'm very pleased to introduce today the 60th Global Health History Seminar. We're very lucky to have two very good speakers today. The topic of the seminar is the WHO International Code of Marketing of Breast Milk Substitutes. And we will follow the normal format in that each speaker will give their presentation and then we'll open it up for questions. So our first speaker is Dr. Sami Shubber, who is a former senior legal officer at WHO. He's now retired and is the author of a book on this topic. He's also served in other roles, has worked at other UN agencies, has worked in Iraq, where he comes from, on the Oil for Food program. He's a member of several important legal organizations, and we're very happy that he's here today. So I'd like to invite Dr. Shubber to make the first presentation. Thank you.
Thank you very much, Dr. Momen, and I'm delighted to be with you again after a long time, a long absence from WHO. I'm going to talk about some legal instrument which has received so much attention in the late 70s, early 80s, within WHO and outside WHO, and the controversy that has arisen since and continues. I'll be briefly talking about the history of the International Code. Then I'll make some observations about the various stages of the Code and what happened or what were the issues raised against WHO, for WHO. And then I'll be very happy if we could have questions or discussions. The WHO International Code of Marketing of Breast Milk Substitute, I will start calling it the International Code, started in fact in 1978. But WHO was involved in this issue earlier on because the promotion of breastfeeding and the infant health and mother's health is a health issue which falls within the competence of WHO, even though this was objected to later on. So in 1974 and 1978, WHO, the Assembly, adopted two resolutions on the subject, drawing attention to the problem of decline of breastfeeding, the risk to health from the promotion of breast milk substitutes and the publicity that it was receiving at the time, and called on member states to take measures to promote breastfeeding and discourage these unhealthy propaganda and promotional activities. But the real work began really in 1978 upon a request from the late Senator Edward Kennedy to the DG of the time, Dr. Mahler, requesting him to adopt or to work on an international code that would deal with the matter of breast milk substitutes and the issue of health related to it. So Mahler responded positively, and a meeting was arranged in WHO in 1979, in October 79. This meeting was really the beginning of the International Code. because it was held in Geneva 9 to 12 October 1979, in which 150 members, persons if you like, participated. They included people from governments, people from NGOs, people from international organizations, and so on. And this meeting recommended the adoption on call on WHO and UNICEF to work on the development of an international code to deal with the issue of breastfeeding, promotion of breastfeeding, and the issue of use of breast milk substitutes and the promotion therefore. After that, the Director General started work on this. And then the Secretariat prepared a draft. In fact, we have, and within WHO at the time, we had 4 drafts of the international code. The first one was immediately after the meeting, the October meeting. It was prepared by an American professor and brought to WHO and UNICEF, and it was called the first draft. That draft was a bit awkward because the man who prepared it was an academic. He was not familiar with the practices of WHO and UNICEF, with the work of international organizations. So it had quite a few provisions that were not acceptable to the organizations. Then, after that, WHO decided to hold consultations on the subject. There were actually 5 consultations on the subject to which this draft code was submitted. The first consultation was with the interested UN agencies and WHO and experts from WHO various regions. This was held here in Geneva in February 1980. A second consultation was held with NGOs, consumer groups, again in WHO, in February, a week later, in February here. The third consultation was held in Paris with the bilateral agency, the donors, like CEDA, the Canadian and country CEDA, Denmark, Norway, and so on. The fourth consultation came back to Geneva. It was held here in March 1980. To this consultation were invited professional associations like the Red Cross, the Society of International Midwives, experts from various regions of WHO. The fifth consultation was held here again in March, to which the infant food industry was invited. That's Nestle and the ISIFI, the representative, and so forth. Following these consultations, a second draft of the international code was prepared. This second draft was submitted to the WHO Assembly in 1980 for its consideration and advice on the subject. It was amazing because I've never seen so much attention and so many speakers wanted to speak. There were more than 54 delegates who put their names on the list of the chairman of Committee A, and all spoke on the subject. Then a resolution, a draft resolution sponsored by 44 member states was submitted to Committee A and was adopted without any opposition but with 2 abstentions. The interesting thing here is that in 1980 the United States was very favorable to the international code, and they were among the sponsors of the resolution, because at that time it was the Carter administration, the Democratic Party, and they told us if there is a change in the administration there will be no code from the point of view of the United States. Then the draft resolution went to the Assembly, and the Assembly adopted it in unanimity. Now, the Assembly asked the Director General to prepare the international code in two versions. One as a recommendation according to Article 23 of the Constitution, and the other version as a regulation according to Articles 21 and 22 of the Constitution. Briefly, the difference between these two instruments from a legal point of view is this. Recommendations are generally not binding, whereas regulations are binding on member states unless they notify their reservations or rejection of the regulations. So the DG was given this choice, and you will see later what happened. After the Assembly, the Director General started real work on the International Code. The first thing that happened, the steering committee was appointed by the DG, in which were represented various disciplines. There was an ADG, Dr. Tihada, the Family Health, Legal Office, and so on. And this committee was concerned with the preparation for the International Code. The first thing it did was to have an outline, a timetable for the activities, so that the code, the draft, can be with the Executive Board in January 1981. Then a drafting group was formed. We were about 4 of us. Legal office, I was there, and the technical unit were represented. The draft, what we call now the third draft, which was prepared, was sent to all member states and the industry and all people concerned. Then 2 consultations were held again. One in August, one in September. The August one had the NGOs, the industry, and so on represented in it, whereas the September consultation was reserved to member states only. We had 4 states from each region invited, and then 4 states wanted to be invited on their own. So the consultation was held, and it went all right. But of course, in all these consultations and meetings and so on, there was always heated argument, discussion, difference of opinions, and so on. Following these consultations, the Secretariat prepared what we call a third draft. We've taken into account the comments of the various member states. Then this third draft was okay after these consultations. We sat together and took into account the points of view expressed during the consultation, the comments made, and a 4th draft, which was the final one, was prepared by the Secretariat and was completed in October 1980. In fact, the final touches were put on the code at Cambridge University because we had the benefit of the professor of international law at the time, Sir Robert Jennings, who was the head of the drafting committee. And that 4th draft was sent to the Executive Board in January 1981, and the board considered it at the time. In January, the 2 alternatives, regulation or recommendation versions, were considered by the board. And there were people, members of the board, who preferred regulations, which would have had a binding effect, and others preferred recommendations. Finally, the board decided to adopt the recommendation version in order to maintain unanimity within the membership of the organization. This recommendation went to the Assembly and was adopted by the Assembly on the 21st of May, 1981. But during the Assembly, during Committee A, there was again a lot of discussion, and 50 member states wanted to speak on the subject. But only after 10 spoke, the debate were closed, and so the debate did not continue. And there was a voting on it, but by roll call, because some member states wanted to know the position of each member. So there were 93 member states in favor, 3 against, and 9 abstentions. When it went to the assembly, to the plenary, again there was a roll call, and were 180 members in favor, 1 against the United States, and 3 abstentions, which were Japan, South Korea, and Argentina. And on the 21st of May 1981, the Assembly adopted the International Code, and that was the end of the involvement of WHO and UNICEF. Now, I have some observations which I would like to share with you. First one, the subject matter of the International Code was a health issue. Therefore, it was within the competence of WHO from a legal point of view. This was disputed by some people in the industry, in the private sector, or the public sector. Secondly, WHO and UNICEF adopted a democratic system of consultation with member states, with NGOs, with the infant food industry, and so on. So the process was perfectly democratic. The third point is that the infant food industry at first tried a soft strategy to influence WHO. So they said, we will send our experts to sit with you to draft the code. We said no. Then they said, we would like to give you our own codes that you can use. And we said no. Then they said, look, when you prepare the code, you have to make a distinction between developed and developing countries. And we said no, and the Assembly said no. So when this has failed, after January 1981, there was a tremendous, a very hostile campaign against WHO. In the press, in the State Department, even in the White House, in the Wall Street Journal, in the Herald Tribune, the Washington Post, and so on. But WHO stood fast, and finally it went on to the Assembly. The fifth observation is that the preparation of the International Code was done by the Secretary of WHO and UNICEF, and with the help of some consultants. But neither the infant food industry nor the NGOs have taken part in it. And it was amazing to see that 20 years after the adoption of the code, the representative of the infant food industry claimed that the IMF was proud to have taken an active role in the formulation of the International Code of Marketing of Breast Milk Substitute. What a big lie. But unfortunately, no member of the WHO Secretariat challenged this statement and this lie, and went on. The sixth observation is that WHO, when preparing the International Code, received tremendous support from member states, from the Assembly, from the Executive Board, and all over the world. And it was decided by a roll call. Now, again, the industry claimed that the code was adopted by a negotiated consensus. The last observation is that, unfortunately, within WHO Secretariat, the code has its ups and downs. The first few years after the adoption of the code, there was a lot of enthusiasm and support for it. Then this waned. And I remember going to a meeting in Canada, Ottawa, in 1985, for a Codex Alimentarius meeting. I was instructed in writing by the then legal counsel not to mention the International Code under any circumstance. I had to, of course, I had to obey. And then when Nakajima came, things were all right, I think. But during Brundtland era, I think things were not so good. And the code was considered as a liability. But I think within the present administration, the code has received good attention, and this is a case in point, this seminar, and asking me for it. Thank you very much. I'd be happy to discuss anything.
Thank you, Dr. Shubber, for setting the scene and giving us your experience on this. Before we open up for questions, I'll now ask Dr. Francesco Branca, who's the director of the WHO Department of Nutrition for Health and Development, to present the WHO position and the current activities of WHO in this area. Thank you, Dr. Branca.
Thank you very much, Moman, and good afternoon, everybody. I think it was very interesting presentation. To learn this history is always very important, and thank you, Sami, for providing some of the insights. We've read, of course, reports, but learning it from the person who actually was involved in it is a different story. I was asked to tell you about what we're doing to improve infant feeding practices currently. But I think I'd like to tell you immediately the follow-up of Sami's history. So I'd like to go here and tell you where we are with the implementation of the code. This is an analysis which was done in the last, in fact the report is about to be published next month. Carmen is working on it. And this analysis was done in the last couple of years, so we hope it's relatively updated. And you can see that there's an analysis of a number of countries that have taken up the code and transformed them either in law, including all the recommendations and, in fact, all the follow-up resolutions. The second column is countries that have taken many of the recommendations. The third column is the countries who have taken few recommendations. Then you have a series of other possibilities. Some countries have actually decided to go for the voluntary measures, or even some voluntary measures. Some countries have still codes in a draft. Some countries are still thinking about it. Some countries are actually putting in place actions to end distribution free supplies only, and some countries have no action. For some countries also we don't have information, which is a sign that probably not very much is happening. So in reality, if you take the first three columns, you add them up, and in brackets you have what we call the territory, so it's not member states. We have 103 member states who have done something about the code. Now what do? Mainly they prohibit promotion of designated products to the general public and health workers and in healthcare facilities. They have some provisional labeling requirements. Some have provisions on contamination warnings and bans on nutrition and health claims. So these are the things which are picked up in most cases. So overall, you can say that perhaps half of the member states have been more determinate in following up on the code. But at the same time, I need to show you this other slide, and this is something about the implementation and the monitoring of the code. So in reality, while legislation is in place in many countries, in reality, the follow-up and really the holding the stakeholders accountable for the implementation of the code is only implemented in a number of countries, in a smaller number of countries, which is in fact 1/3. So we have documented reporting system in 37 countries, partial reporting system in 14. There's also a number of countries where it was difficult to find accurate information, but again, it's a sign that the systems are not in place. So this is still not a closed history. This is very much ongoing history. In fact, that one of the important activities that WHO is working on is to really find better ways to look at the implementation of the code and the monitoring of the code. So now I'd like to go back to what I wanted to say, and I'd like to say also that really infant feeding is addressed in different parts of the House, but particularly by two departments, by the MCA department and the NHT department. So for me it's a pleasure and an honor to just represent all of us, but it's definitely a joint responsibility. What's happening in nutrition? And this is relevant for the discussion of today. We still have a large number of children affected by chronic undernutrition, and that's a reality nowadays. So it's not any longer the acute malnutrition crisis we used to have about 20 years ago. That's the wasting type of thing. It's a stunting. It's a chronic undernutrition, which still, as you can see, affects a lot of the countries in sub-Saharan Africa, still Southeast Asia. 171 million children we counted in 2010. Why stunting is important? Because it has, together with wasting, an impact on mortality. You see childhood malnutrition is the underlying cause of deaths in about 35% of all deaths. So we're talking about 2 million children dying each year as a result of undernutrition. And overall, maternal and child malnutrition account for 11% of the global burden of disease. So we're definitely talking about a very important determinant of that. But stunting particularly is also somehow giving you a mark in life. So if you're stunted, you're going to be a smaller stature, you're going to have less muscle mass, you're less able to do certain work that demands your body. There's also a problem with poor cognition and educational performance. This all reflects comprehensively in lower productivity and adult wages. So you basically are caught in a circle of poor health and increased risk even of chronic disease, or even the longer-term health is affected. And it's an intergenerational cycle. If a woman is stunted, then her child is likely to be born with low birth weight, and again, it's a cycle. So what has happened in developing countries? There has been a healthy trend in Asia with a decrease in the last 20 years of stunting, also a decrease in Latin America, but Africa really has been more or less stagnating. And in fact, if you look at the actual numbers, you can see that in Africa, the actual number of stunted children for the demographic trends is increased. So that's where more or less the 171 come from. Still a larger amount in Southeast Asia, but then an increasing number in Africa. But this has to be considered at the same time with another emerging challenge, which is the challenge of overweight prevalence. And this is children under 5 again, and you can see that basically everywhere we have an increase. And remarkable is the increase that you observe in Africa. So childhood overweight is not only a problem of Europe and the US. It is a problem of North Africa, for example. It is a problem for the Eastern Mediterranean region. And you see, we now have about 43 million children under 5 who are affected by overweight. And this is all relevant for our discussion today. Some countries have been doing very well. This is the reduction rate of stunting. In the reduction rate of stunting, you see you have countries like China, Brazil. Brazil is a success story for excellence, because it really has been targeting the reduction of malnutrition with comprehensive health, educational, social policies. But what's happening to breastfeeding? Breastfeeding, probably as a result of a collective effort. It was not only the code, it was really a movement, global movement towards the promotion of exclusive breastfeeding. It did extremely well in the 80s. So you see, we had very low rates in the 80s, about 14% global exclusive breastfeeding rates up to 6 months, and it almost doubled, in fact, more than doubled in the next 5 years. And then since then, it's sort of more or less staying flat, and now we're seeing a decrease. Why is that? Life is changing, again, culture is changing, but the factors that are determining the choice of women are probably not changing. So the marketing pressure is still not resolved. The legislation, the maternity legislation laws are still not allowing women to have enough time to dedicate to breastfeeding. Still, we do not have in place the health system provisions that facilitate the promotion and protection of breastfeeding. Some countries have been doing extremely well in breastfeeding when adequate interventions were put in place, and you see some of the red arrows are the success stories. Look at Sri Lanka, 14 years, they went from 17 to 76% exclusive breastfeeding in under 6 months. and a lot of other very interesting success stories, more or less in all parts of the world. Look at Colombia, for example. Look at Ghana from 7 to 54. Look at Turkey from 7 to 40. Again, in a few years. So that is a demonstration that good policy can make the difference. But we also had significant declines for exactly the same reasons. And again, look at a situation like that of Burundi, almost half, or Morocco going down. Again, when good policies are not in place, then that's what happens. It declines. So this has to be a sustained effort. In recognition of the need to have that sustained effort and to have good policies in place, the World Health Assembly again requested the Director General to take action and to develop a comprehensive implementation plan on infant and young child nutrition. And this plan is now going to be discussed at the Assembly in May, next May. Member States requested that, together with a plan, the Secretariat to propose a series of global targets. And the discussion is still open. It's actually quite a tough discussion with a lot of different opinions. And again, with the issue of, should we have global targets? Should we have country targets? What's the time frame for it? And what number do we want to achieve? And I'd like to call your attention to the fact that certainly there is a proposed target on the reduction of childhood stunting, which is a 40% reduction of the global number of children under 5 who are stunted, meaning 40 million children less in 10 years' time with stunting. But also a target about exclusive breastfeeding rates in the first 6 months of life, and the target would be to bring that 35%, which is not a good number, to at least 50% globally. So that would mean certainly a big step forward, similar to what has been achieved in the 80s. The plan acknowledges the limitations of the politics, and it says, well, we need to have a supportive environment. We need to have multi-sectoral strategies. We need to have governance. We need to have investment. But then it also tries to say, okay, what is the package of intervention that needs to be put in place that is going to change nutrition? So I think WHO made a big effort to try and formalize that package. And we always have to remember that although we target maybe a window of opportunity in the life of an individual, that time from conception to early infancy, the first 2 years of life, where we're sort of more sensitive to this type of environmental insults, we have to have a perspective of the life course. So adolescent women have to be targeted in the first place with good nutrition if they want them to be in a situation to have good conception, and then the child who is born has good chances not to enter the malnutrition cycle. So what does WHO do in general? First of all, we need to make clear what the science is, what the recommendations are, and what the policies should be. So we do work on nutrition program guidance, and luckily we have some very good people in WHO who help us, giving us the good directions on how to do this in our guidance review committee. So we set up a nutrition guidance advisory group to do this, and we put everything together in a place which is called the Electronic Library of Evidence of Nutrition Action. So where all this guidance is really consolidated, you find summaries of the evidence, and you find all the actual material that is contributing to the guidance, and the guidelines themselves, of course. You also find commentaries, biological behavioral rationales that explain why we should undertake those interventions. WHO has had a very important role also in setting standards to understand what is malnutrition. And in 2006 we had the approval, the adoption of the launch of the growth standards. We now have also some references for 5 to 19 years. We have growth velocity standards. We have a lot of softwares, and this was suddenly very popular. And in fact, we have now 127 member states who have adopted WHO growth standards. And I heard recently that China is adopting US has adopted up to 2 years. So that's a common understanding of how we can define malnutrition from the point of view of undernutrition, but also from the point of view of overweight. So the information side of it is very important. What WHO does is trying to consolidate the information that we have on malnutrition. We have a series of databases, and the Nutrition Landscape Information System is consolidating all these databases. We're trying to develop also a database on the implementation of programs, where we will have information on code implementation, and we will have information on the different aspects of infant and young child nutrition policies, and we hope to launch it later this year. Then specifically, of course, we provide assistance to member states on certain topics, and on requests for sure, but there are some topics which are requested very much by member states, and the management of severe acute malnutrition is an important one. So although we've, I think, collectively done extremely well, member states have done extremely well in reducing malnutrition rates, still this is a scourge in many parts of sub-Saharan Africa. So the work on updating national protocols, training of health workers, providing supplies for inpatient care, linking inpatient and outpatient care in community-based of acute malnutrition are important aspects. On infant and young child feeding, the packages that we really are working on the protection, promotion and support of appropriate infant and young child feeding. So one element is the exclusive breastfeeding, but the other very important element is the complementary feeding. So what happens after 6 months and up until 2 months in terms of the availability of food, right quality of food, and so identifying the appropriate options is something that we're working on. Health services is something that WHO is very good at, and making sure that the promotion of breastfeeding is part of any health service package, whether it's IMCI for children, whether it's impact for antenatal care, or whether it's pre-pregnancy packages, something that we're working together on. We need to make sure that those interventions are there. But one particular thing I'd like to say, that the capacity building of health workers is probably key. So having a course which is now integrated with the growth assessment is something that we're trying to do, and you see that there's an adoption of the integrated course in several parts of the world. We need to broaden that map with the help of our regional and country offices. And this is a very interesting initiative. You're certainly familiar with it. It's called the Baby-Friendly Hospital Initiative. So basically, it's a concept of having a hospital that is facilitating the early start of breastfeeding. It's facilitating the transmission of information to the mothers to help them on how to learn how to breastfeed, and it's creating an environment which overall allows breastfeeding to start properly. And this initiative has been taken up in many countries of the world. European countries are perhaps more advanced, but you see, I think that again, it is a history of a partial success, and you can see that in some parts of Europe, for example, only probably still a minority of the hospitals are baby-friendly, 20%. If you go to some other parts of Europe, for example, Norway, you have 80% of the hospitals which are baby-friendly. And this, of course, will immediately reflect on how we implement the infant and young children recommendation. Needless to say, no free samples in these hospitals. So I think I just would like to finish here, but I'd like to, coming back to the point that Sami is saying about the current administration. This is what Dr. Chan said at a meeting in New York in September, called at the side of the high-level meeting on the NCD, and there was a high-level meeting on nutrition. She was there, the Secretary General was there, the Secretary of State of the US was there, several Prime Ministers, Presidents were there, showing that nutrition is really a priority for many countries. And that's what she said. She said, we know what to do. We can reduce maternal anemia, low birth weight, and child stunting, and bring down the risk of non-communicable diseases within a generation. We can achieve this by giving nutrition the attention it deserves. And I think this is a very good message. So I'd like to leave you with this, and I'm happy to have a discussion with you all. Thank you.
Okay, well, I'd like to thank the two speakers, and now I'll hand it over to our co-organizer, Dr. Shane Rook from the University of York, who will facilitate the question period.
Okay, I'm very happy to throw the question floor open to the floor now. So, man.
Hi, thanks very much for a very informative, enlightening speech. I have seen personally the marketing pressure in hospitals in the Philippines where free samples were given out, and I spoke to the social workers who were doing that. The samples actually said Nestle's on them. And I asked them, are they teaching the mothers how to boil the water, for example, or how not to dilute the infant formula, etc. But that wasn't being done. They were just handed out. It seemed that the marketing pressure was quite severe. I guess my question was, with respect to the code, and for those organizations that are violating the code, is there any possibility that we can change the recommendations to regulations? And what is the role of the United States, and what steps can we take from this point forward? Thank you.
Yes. Well, from a legal point of view, it is always possible to transfer or to alter the code from a recommendation to a regulation which is binding. But from a practical point of view, I am afraid it's not possible. And the United States has changed its attitude after the Reagan administration has gone. And I think they have been cooperative until I left WHO. I don't know now.
Yeah, thank you. I'd like to add something what Sami said. It is up to the countries to decide how strong a legislation they want. And some countries do have strong legislation. So definitely what is important is that there is perhaps a demonstration of the impact of current measures. And in the last two assemblies at least, there was a comment about that. And in one of the resolutions, it clearly says that it has to be acknowledged the voluntary schemes are not that effective. So there is a call for legislation with accountability framework. The problem is the accountability framework and what happens if, are there any sanctions? At least a name and shame type of approach to companies might work. And as you know, Nestle was very strongly hit by an embargo, which is actually still going on. And still WHO doesn't work with Nestle. And still UNICEF doesn't work with Nestle. So the fact that there is such an approach on a clear analysis of confidence behavior is quite important. WHO doesn't have the mandate to watch companies. I mean, that's not our task. It's member states who have to do that. At the same time, I must say that there are several initiatives who are trying to look at accountability systems. We don't know whether these initiatives are going to be good or not. There is, I don't know if you're aware of what is called the FTSE for Good Index. So basically these are rating companies who rate companies based on a series of indicators for investors to decide whether to invest or not. Nestle decided to enter that system, so they're going to be audited by PricewaterhouseCoopers on just to see if they can stay in the index. So the Nestle, for example, would like to overcome this. Other companies are less willing to engage in that. In fact, some of these companies are even demonstrating, they're trying to come with a system to look at the enforcement of the code. So if this really happens, things like those you quote in the Philippines should not happen because they should be reported. But probably our task would be to try and really make sure that we have a good understanding of what's on the ground, a good mapping, and we circulate the information. NGOs are very good at that. So NGOs also have the freedom to do that, and IBFAN produces a biannual report on the performance, on the violations of the code, and that's a very useful piece of information.
Let's have a word about the implementation, Dr. Branca said. When the Assembly adopted the code, it recommended that the code should be implemented in its entirety and as a minimum measure. Therefore, any partial implementation, I'm sorry to say, is not a proper implementation. And as Dr. Branca said, member states are fully entitled to go even beyond the code if they want to. It was a minimum measure and it was a compromise. Thank you.
Thank you very much for both presenters. I learned a lot. I didn't know too much about the history, as you said, of the International Code, and I was very amazed to know that it was Edward Kennedy who first came up with that. I was a medical student. I'm a pediatrician myself, so I lived through all those things. And I just like to comment and pointed it out that the adoption of the International Code opened any avenues for the baby-friendly hospital, for the humanization of neonatal care, for rooming in facilities, and increased the number of breastfed children. I'm from Brazil, and I, as I said, lived through all this moment in my medical residency. And today, I mean, all the Nestle Milks or whatever other companies that produce infant food, they write in their little cans that we promote the International Code, and you should breastfeed until 6 months, but after that you can use this, and that. And I didn't know that it was not a resolution and just a recommendation, because in my country, I mean, it was adopted by the law, right? So it was very nice, and thank you very much for this historical point of view.
I'm from Essential Medicines, and we looked at how you got the code done. For us, it was a gallop. You know, from 1979, you got it done in 1981. We in medicines are still trying to get our code of advertising done for a long, long time. And I think medicines were the kind of collateral damage that occurred because of the infant breastfeeding code, because they realized what was coming and they sort of knew how to protect themselves. That was the first point that I wanted to say. Second point was, I'm Sri Lankan, and I was quite proud to see that we had gone up to 75% in exclusive breastfeeding. In our part of the world, trying to highlight the violations of the code, actually the levers of power are not in the country itself. If you take an example like that and show it to the local multinational subsidiary, nothing really happens. You show it to the regulators, nothing really happens, because they are all, I do not know, whatever the milieu. The best method to do it, and it has been successful, is then to send it to headquarters, whoever is enforcing it, and also copy it to some of the international NGOs. You break the whole process open, you make it accountable, and then you find, we have found on some occasions, the enforcer from the headquarters comes down to the country and then starts reading the riot act. So, I mean, that's one of the ways of getting it enforced. Local enforcement really doesn't work in most of the situations.
Excuse me, it could work if you have a law that will make it accountable, make any company that violates its provision accountable to Sri Lankan courts and jurisdiction.
So the question is, who is going to institute that case? You know, I mean, is this a priority? Is the government going to institute it? That's one of these things. You tell the government, they'll say we have much more priorities. Not only because they have much more priorities, but there are other influences pushing this down. So, I mean, it has to break in an open international forum to then force the local participants to do that.
You can do it. You can give anybody the right to take any violator to court. In India, they give the NGOs or an individual the right to complain against a company, a food company that violates the Indian court. So it can be done if there is a political commitment. Thank you.
Yeah, certainly it's quite important to see what happened in Sri Lanka, India, and as Sam was saying, the role of the NGO I think was really key. And we have a very active NGO group in that part of the world, very strong advocates and very careful assessors of the situation. That is in fact a potential way forward to set up monitoring systems. So basically set up complaint system, as it happens in many countries, using consumers associations to channel that and to create clear basically demonstration that some of the companies' policies are not implemented. And I agree with you that then creating this case and making it known internationally will change companies' policy, because companies have really suffered by the damage in their image. Some of these companies are now, as you know, talking about shared value. So for them, this element of contributing to public good is essential. So a good reporting system that names and shame companies for what do they do, managed independently through civil society, would be, I think, a powerful way to address this.
Thank you very much. I'm sorry I missed the beginning of the presentation, so maybe my question was already addressed. But in thinking of different ways of accountability, not only maybe the ones that have been already used, has there been an attempt to link this with human rights, in particular children's rights, perhaps either from WHO or UNICEF or other agencies, as part of the watch, as another way to say that, well, breastfeeding is actually a right, not just something that can be decided? Thank you.
I think there has been some hesitation about making it a human right, but the Convention on the Rights of the Child, Article 24, encourages or makes it an obligation on member states to encourage breastfeeding as one of the means of attaining health for the child. Thank you.
I'm Cota Ballenas. I used to work in child and adolescent health some time ago on infant feeding issues. And in fact, the human rights issue, very interesting. It was, as Sami says, linked with breastfeeding. And that's how the child rights officer in the department started moving more the issue of the code, because countries, when they were reporting to the commission, they were the committee, the human rights committee. They were also asked to inform on what were they doing in terms of the code and breastfeeding in general. So that's how he started getting involved in that, and then he started working more actively on the code. And so it is an issue, and I think that's also a way of working locally to push the code in terms of human rights. So, just to add to that. But I had a comment. Can I? I think this is thanks so much for all the two presentations. I've always been interested in this because it's a very political issue. The context is so important, and it's been going on for years and years, more than 30 now. I think I've always been interested in this, in the history of the code, because I think we need to learn from the past mistakes. And from what the colleague was saying, it seems that it's not only us who want to learn from our mistakes, but the industry also learns from their own mistakes. So now they don't want any code at all, or at least those codes that would contain marketing. I was wondering, from the past mistakes, what would you say if we were to recreate the code? And just as background, you know, we have the Code of Marketing from 1981, and then we have the subsequent relevant resolutions. So the code has to be seen as a whole with all those resolutions, because the code, when it started, it still had many loopholes. So the resolutions have been trying to strengthen it. And we kept getting questions, okay, are you going to have a new code? And for us the answer was No, because we have all these things. If we were to try to create a new code with all these resolutions, the political context wouldn't be there, perhaps. Perhaps I'm being too pessimistic, but what do you think?
Sorry, Dr. Quite honestly, I don't think we'll have a new code, given the present circumstances and the pressure that has been brought to bear on the organizations and so on. But there is enough. The code is not a perfect instrument, but it's a workable instrument, and it's a minimum measure. So any member states implementing it can go beyond it and include relevant WHO resolutions, which, as you rightly say, have sometimes clarified, sometimes added, like this six months exclusive breastfeeding is, I consider it a de facto amendment of the code. So there is this opportunity, but a new code, I'm afraid, won't be possible.
Yeah, I think, Kota, you make a very important point. The code is a living organism, and we would like it to be a living organism. So it evolves continuously. There are new situations and that require addressing. For example, there has been, after this, of course, discouragement of the use of infant formula, a response from the industry, which was to then work on the older children. So they invented the follow-on formula, which, as we know, and it's written in one of the WHO resolutions, is not needed. So after 6 months, you can go to another food. You don't need to have a follow-on formula, but still, it's been invented. So is marketing of follow-on formula allowed, and does the code cover it? And we have had complex discussions about it. But this is a type of element that should come in our understanding and implementation of the code. Then, and this is again coming at the next assembly, people are saying, what about marketing complementary food? Because if we're moving more and more into an environment where food for children is actually provided by industry, and it will have claims, it will have labels, it will be advertised, how would that affect, for example, breastfeeding? So in a sense, there is a spirit of the code which needs to be continued through a series of other measures which will complement the code. I also believe that we need to ask ourselves, is the code the whole story? Because we need to understand where to put our energy in terms of policies. Definitely the code is a very important part of the story, but we also need to consider there should be other elements. In maternity legislation, for example, as you know, it's a very complicated one. Even in WHO, we probably do not have the ideal environment for the promotion of breastfeeding up to 6 months because of the regulation of maternity protection. But there's many countries where the condition of labor of the women are such that breastfeeding becomes very difficult, and that's a reality. That's why we're actually seeing lower breastfeeding rates in Southeast Asia, because more women are working, and they can't afford to go and breastfeed, so they end up going on the infant formula. So I think we need to also to see the code as one tool in the context of a comprehensive policy of infant and young child feeding.
Actually, we were very happy with it, but on the understanding that it is a minimum measure, that it was a compromise, and that member states can have the liberty to go beyond it and elaborate some of its provisions. Some of the provisions are so general that they could be interpreted in reality in laws in different ways. For example, including the maternity leave. There's a provision calling on member states to take measures to encourage breastfeeding. And this could be a basis for providing for maternity leave, providing a place on the workplace for breastfeeding periods and so on. And some countries have done actually provided some breastfeeding places at the workplace. So in general, we are happy with the code as it was. Thank you.
Yeah, one question to Sami. Every 2 years we report on our progress in the implementation of the code. And when we report to the Assembly, we try to paint the picture as positive as we can. However, when we look at the pictures with sort of a sharper eye, we have about a fifth of the countries that have really sort of implemented the code in full. In the early years of the code, we have WHO providing a service to countries that wanted to develop the code and have it as part of legislation. This disappeared over time. I wanted to see, Sami, as you were involved during that period, which ways you think WHO might still take an active role in helping countries to move towards adoption of the code and, if possible, sort of having it as legislation?
Well, I regret to say that the reports I have seen, the 90s and so on, about the implementation were not true. The territories and states that were reported to have implemented the code were not implementing the code. The review, I don't know who's done the review, but it did not come to legal. There's a country which has adopted 4 or 5 provisions of the code and was considered as implementation of the code, which was not true. But how we see WHO, I think Dr. Branca would be better qualified than I am, but I think we should try to enlighten member states, educate member states through the holding of seminars, the holding of workshops, as we did in the 90s, and where member states are invited and informed that what are the advantages, what are the benefits for their society, for their own countries, for their own financial situations. WHO can do that. The WRs can also take the initiative to do something. I had the privilege of going to about 10 or 12 countries where we did lay down some legal instruments, but they were all shelved because the political commitment was not there.
No, I think it's a very important question. Also, particularly now at a time when we are struggling with resources, we are cutting staff, and it is true that if it's a priority, we must find a way to do it. One important element would be the knowledge about the code among our own staff. So for this purpose, actually, the MCA and the NHD department worked together on a very interesting course to explain the code for marketing breast milk substitutes. So I think we need to have that information. That's number one, because we would then be able to help countries at country level. I mean, we're moving into an era of greater country level capacity to advise technically and politically. So I think we need to empower our staff to do that. That I think is number one. Number two, I think we have some good examples in some regional offices on assistance to on the code. Western Pacific, the Philippines that you were mentioning, actually there was quite a lot of initiative in the Philippines at high political level to implement some of that. Then with variable results, but there was that effort. The PAHO group is the man who's coming. the man of the code, Marcus. So I think that at the regional level there is quite a lot of effort. I think the energy would be best placed in us helping on monitoring and establishing networks of monitoring groups, to not just WHO staff but NGOs and collaborating center academicians, and then put that in a visible place, give transparency, so have a database of code instruments as well as the measures to implement the code. I think that's compatible with our current resources.
That's it, it's on now, yeah, I've got it, thanks. It would seem that support for breastfeeding remains a small part of all the much-needed child nutrition activities. However, breastfeeding is of interest to global health primarily as an infant and child survival issue, as well as a woman's health issue and a fertility issue. What is being done today to increase resources for breastfeeding as all of the above? Support for women, reduction of excess fertility, education of health professionals, and enforcement of the code. From Miriam Labok. Who would like to take that? Francesco?
Yeah, thanks for the question. I think the issue of resources is essential. So the first thing we need to do is make sure that the commitment is there. So interventions to improve breastfeeding are on top of the life-saving interventions. And sometimes this is not happening. We refer to a series of technological interventions to improve child nutrition, whereas we should really highlight the importance of breastfeeding as number one measure. So that's, I think it's something which we are able to do. In terms of investments, the investments probably should go to ensuring that health staff is able to provide the support and is less inclined to be persuaded by the private sector to give the wrong advice. So I think any initiative on strengthening the capacities is quite important. The issue of women's support is also extremely important, but I think that, again, that's a policy measure. It's a legislation part that needs to be addressed. This is not something that WHO can do on its own, and I think CONA has been working quite a lot with the International Labour Office to see how we could at least explain what are the issues around maternity protection and what type of tools there are to improve that maternity protection. So probably these are the three very concrete things we can do. And of course the fourth one is what I mentioned before, it's the monitoring side. These elements are included in the provisions of the comprehensive implementation plan on maternal, infant, and child nutrition. We make it very clear. We believe that that should be really a package of actions at country level that for policy makers to consider. And in our discussions, for example, in our work on scaling up nutrition, that is something which we're going to discuss with them. So the financial investment is something that we believe should be done certainly by the international community, but it should be done at country level. So the resources for nutrition should come in the first place from taxpayers' money of the countries where the burden resides. And that's not impossible. There are several financing tools which have been considered. In fact, in the context of the framework of the Secretary General for Maternal and Child Health, there is already quite a lot of commitment from some of the member states on financial resources. Correct me if I'm wrong, Jose, but breastfeeding is also part of that of the strategy, the Secretary General strategy. So I think we have a series of very concrete tools for this to happen.
I think the enforcement of the code would be a very good action that could encompass all these elements of the policy and the practical implementation of the policy on nutrition and so on. But the resources, I may just one comment. In the in the 90s, we've had a lot of support from member states in this area. For example, I remember the Dutch government gave a big donation to WHO to be used for promoting activities on the implementation and other aspects of the international code. So we were able to hold workshops. I went on missions to implement the code, and there was enough funds to pay for that. We can, as Dr. Francisco said, we can return to this approach and see the international community is prepared to support us in this respect. Thank you.
At UNICEF, where I was the senior advisor on infant and young child feeding, we definitely built upon rights. And in the 1990s, UNICEF pushed considerable resources into breastfeeding support globally. And the USG started its support for breastfeeding. Since about 1999, the resources available for BFHI and the code support in terms of resources and energy at UNICEF diminished significantly. Is there any effort to restore these resources so as to undo the declines that we have seen in exclusive breastfeeding? And that's from Miriam again. So, yes. Francesco?
Again, it's a very important point. I can't answer, of course, for UNICEF. I can say that jointly with UNICEF we've been considering this, and we've been thinking about initiatives to actually target some of the important actions that would improve breastfeeding rates. There seems to be some movement together with NGOs to make this happen, and there will be in December in Delhi a global breastfeeding promotion conference convened by IPFAN, for example, and with the support of UNICEF and WHO. So we definitely will try to do the advocacy side, which is required to then mobilize these resources. As I said, resources are very limited, and the point we have to make is that if a country is planning to address malnutrition with scaling up interventions, it doesn't spend half of the money that is calculated to be needed on supplies, but it actually invests on human capacities, invest on legislation to create the environment for this to happen. And we have a few examples like that, and probably even by changing the tools to design the comprehensive policies, we can make that change. We have a very interesting tool which WHO together with other UN agencies is developing called the One Health tool, which does the costing of interventions. And so you can really develop a planning for the country that includes a series of components. So making sure that the right components are in their tools will guide countries to make the right choices. At the moment, the tools that are available somehow suggest that addressing moderate and acute malnutrition has to be done through ready-to-use supplementary foods. That's currently not WHO policy, and if you the example of Mozambique, for example, if you calculate, if you see the costing that has been done, 50% of it goes in the supply. So even changing that type of culture, I think is going to be an important contribution, and that's why I'm saying, we need to make sure to make clear what the benefit of breastfeeding intervention are compared to other interventions, and we need to be very clear about what is effective to improve breastfeeding rates. We're learning from those success stories in those countries, and I think that's the way forward. I don't think we can have the aspiration of having like suddenly new funds, because a lot of those countries are probably shifting their priorities. So what is important to do is to make sure that once there is an investment in nutrition, the right part of it goes to the right things to do. In this case, breastfeeding.
The 2010 Assembly has requested the Director General to do a lot of things in the area of breastfeeding and implementation of the international code. Therefore, couldn't the Assembly also call on its member states to make provisions for those activities? Or the Director General could request member states to make available financial support for these tasks entrusted to him under that resolution. Thank you.
My name is Bernadette Dalmont. I work in the Department of Maternal, Newborn, Child and Adolescent Health, and I'd like to make a comment in relation to the questions and the conversation. I think we are in an era where at least there are sparks of hopes that we can pull things together in the area of maternal and child health under the umbrella of the Partnership of Maternal, Newborn and Child Health. The continuum of care, it has become really a driving principle. And so we see from multiple sides that the aspiration to integration is there, and that includes nutrition. There's just a new document that kind of summarizes the essential interventions, and that includes exclusive breastfeeding, complementary feeding, and that is very well received and is actually the basis for strategy development, the One Health tool that was spoken about. And so in countries we see that when we talk about strategies, increasingly countries talk certainly about maternal, newborn and child health, but also numbers say no, that needs to include nutrition. So with the essential interventions as WHO, where we are planning to do the policy compendium, and so there issues like the code should be highlighted. So these are all sort of hooks that we need to capitalize on and make sort of follow the word by the investment, but it's an evolution from when we look a decade ago where maybe things were more in their silos and was looked upon as nutrition, as child health, as maternal health, and now there is this convergence as an opportunity for us to also push on the issue of the code.